First of all, I would like to thank the Department of Pediatric Surgery, AIMS Rishikesh, especially Dr. Satyatri and the team members for inviting Karl Storz to update you on our latest technology. My name is Sunil Verma. I've been working with Karl Storz for 25 years, but mostly I worked in the neuro and spine department. Only last year they asked me to take care of pediatric and cardiovascular thorax. So I'm new to this and still learning and I hope to learn more. And I had been involved in developing some neuroendoscopy training curriculum in Southeast Asian countries for 12 years plus. And I was invited speaker in some of their international events on endoscopic skull-based surgery mainly. So John Benetton, who's heading the neurosurgical TV of US, has uploaded my detailed lecture on the America YouTube, starting with care and maintenance of endoscopic equipment with special focus on the various components, assembly and application uses of ETV instrument, which should be seen by the paramedical staff and also the young resident doctors. And you can get a lot of insights into this because I have used a lot of videos there collected from experts across the globe. For the resident doctors who are beginning to get into ETV, there are some very good books which Karl Storz provide free of charge. After COVID, the hard copies are not available, so you can always contact us and we can give you a free copy either through the email or a pen drive. So these are excellent books to understand the endoscopic perspective of the anatomy, to understand the equipment, the details of its assembly, the different anatomical landmarks, to understand the endoscopic perspective of the ventricular anatomy, the do's and don'ts in hydrocephalus, etc. So these are excellent books. And at the end of the silver doctor-to-doctor manual, there is an recommended set also mentioned over there. So kindly go through this. There are many books, so I've just given you a glimpse of one of the books. Those who are looking forward for advanced training, course in laparoscopy, in newborns, infant and children, IRCAD is a private body which has 3 branches, IRCAD Taiwan, France, Brazil. I was associated in supporting some courses in Taiwan. This is a glimpse of this. This has 5-star facilities and there are 23 workstations like this, all equipped with high definition video towers. And those who are looking for some exposure of the courses abroad, this is one of the glimpse of the old course happened in 22. You can have a look that what are the contents they teach in these courses. These are for 3 to 4 days course over there, and you can check on their website. And also last year on 24th November, Indore, Dr. Mohit Bhandari is also tied up with IRCAD body, and they are coming up with the center there. Not yet functional, but they have announced. You can check with them, Dr. Mohit Bhandari from Indore. So these are good solutions. I'm going to take you through the various instruments, the components, step by step, what instruments are required when you are especially dealing with pediatric hydrocephalus, in non-communicating hydrocephalus with dilated foramen of Monro, and what are these components. So these are called the Lotta family. It was developed by Henry Schroeder. We move from 0 degree to 6 degree because the moment you put your instrument in, you are actually working in 3D, but you are seeing on a 2D monitor. So moment any critical instrument like scissor comes out, you are able to see it on the visual monitor immediately. So we have the 6 degree. Obviously for pediatric, you can use a smaller diameter sheath, 4.5. And if you want to do a bimanual technique, sometimes there are colitis cases in small children. You might have to do marsupialization and aspirate the contents of this or tumor resection. Then you can use a bigger channel scope there. So let's go through the component, understand, and step by step. So this video explains that.
The Lotta endoscopy system comprises a ventriculoscope, a working sheath, an obturator, various instruments, and several diagnostic endoscopes.
Audio.
The endoscope sheath has an outside diameter of 6.8 millimeters and a useful working length of approximately 13 centimeters. The telescope can still be rotated through 360 degrees within the sheath after the endoscope sheath has been secured using the endoscope holding arm. The endoscope sheath features a circular length marking so that the surgeon is aware of the penetration depth of the...
Now, this is very important because if you made your calculation from the cortex, when you make burr hole, there should be sufficient hemostasis, otherwise the drop of blood keep coming and diminish your image in the ventricle. So these centimeter markings are very useful, how deep you are going in the lateral ventricle after you make a burr hole.
The endoscope sheath in the surgical field at all times. Thanks to a rotation mechanism integrated in the endoscope sheath, the endoscope can be rotated without having to release it at the endoscope holding arm. To allow rotation, the knurled screw on the head of the endoscope sheath is simply released and, following rotation of the endoscope, screwed tight again in order to keep the rotation position steady. In order to remove the obturator from the endoscope sheath, the locking mechanism is released by rotating it until the three groove-like markings on the obturator, locking mechanism and sheath are aligned. The obturator can then be removed from the endoscope sheath. The obturator serves to enable atraumatic insertion of the endoscope sheath into the brain. The ventriculoscope features a high light intensity 1.7 mm Hopkins II rod lens telescope with a viewing angle of 6 degrees. This minimizes the blind spots so that one can see the instruments as soon as it leaves the working channel. The outstanding optical properties of the rod lens telescope ensure good image quality even under adverse viewing conditions. The ventriculoscope has one large straight main working channel and two small side channels. The large working channel has a funnel-shaped entrance in order to facilitate the insertion of instruments. With the straight working channel, rigid instruments can be used which offer tactile feedback. The large working channel has a diameter of 2.9 mm. The two side channels have a diameter of 1.6 mm and can be used for irrigation or for a second instrument when working bimanually. The connection for the fiber. To achieve optimal illumination of the surgical field, the optical fibers are arranged circularly around the working channel. After removing the obturator, the ventriculoscope is inserted into the endoscope sheath and fixed into place in the sheath by rotating the locking mechanism. Once the endoscope has been locked in the sheath, the tip of the endoscope is positioned precisely at the tip of the working sheath. An optical adapter which is connected to the video camera allows the endoscopes to be changed under sterile conditions.
This is an important adapter because when you put a sterile cover on the camera head, you are changing from diagnostic to therapeutic scopes. So sometimes it is not following an aseptic technique. So you can autoclave this adapter, and then from there you can change the different scopes and it will 100% follow an aseptic technique.
During the procedure. Scopes are also inserted via the endoscope sheath. An optical obturator is available for the atraumatic insertion of the endoscope sheath through narrow openings, such as a small foramen of Monroe. This comprises a drilled open obturator into which a thin 0-degree endoscope is inserted.
So sometimes the foramen of Monroe is not dilated enough. So rather than taking the risk of doing a foraminoplasty, you can use this visual obturator. And since it has a hole with a lens, you can put a 2 mm scope, connect with the camera, and even you can enter under vision in the lateral ventricle as you use in some of the trocars in laparoscopic procedure.
Using the optical obturator, the working sheath can be inserted into the surgical site with minimal invasion and under endoscopic visual control. The optical obturator has proven particularly useful when the ventriculoscopy system has to be inserted into the third ventricle through a small foramen of Monroe. A large number of instruments are available for endoscopic surgery. There are biopsy forceps for performing biopsies and resections of smaller tumors. To grasp larger pieces of tissue or to hold membranes, grasping forceps are used. To grip larger pieces of tissue, 2.7 meter tumor grasping forceps are available, which also enable the resection of larger tumors by means of effective tissue removal. Flexible grasping forceps, which can be inserted through one of the side channels, are used for bimanual working. The deck forceps have proven.
This is a very good instrument called third ventriculostomy forceps because sometimes the floor of the third ventricle is moving, though it could be transparent, fine. So when it moves and you directly put a straight grasper, it slips. So this has serrations there. You can untangle the serrations there and it will not slip. So you don't have to go very deep in the prepontine cistern area, and it makes your safe opening at the floor of the third ventricle.
Their worth for ventriculostomy and the perforation of other membranes. And a guillotine knife are available for cutting. These are click.
Sometimes they are thick arachnoid stand. You want to open your liquid membrane, the second membrane. So rather than going with the scissor, you can use that special knife.
Line instruments.
These are more like your pediatric laparoscopy instrument, click line, which you are aware and you've been using for.
This means the shaft of the instruments can be rotated without having to move the actual handle. This considerably increases ergonomics when using the instruments during surgical interventions. Located exactly on the.
So this black marking over here is important because when you're working with 30 centimeter long instrument, you are actually waiting when are you going to reach in the lateral ventricle. So you can come very fast. So moment this black mark comes at the tip of the funnel entrance, your instrument has come exactly at the tip. Further advancement, you will be going in the ventricle because if it's a scissor tomorrow, it could be a little risky.
Funnel-shaped opening of the working channel, then the tip of the instrument is perfectly aligned with the tip of the endoscope. Thanks to the indication of the penetration depth of the instrument in the ventriculoscope, the risk of inadvertently inserting the instrument too far with resulting injury to the brain is significantly minimized. In order to achieve effective hemostasis, a bipolar coagulation electrode.
This is a special bipolar. It has a ceramic insulation there. The property of ceramic insulation is it's a high heat resistant. So when you want to do a point coagulation at a particular area, this takes care of that. It looks like a monopolar, but actually it's a bipolar, and mostly 90% of the bleeding management is dealt with the ringa-lactate warm solution because the isotonic composition is very close with it. But in case of any bleeding, this is a fantastic bipolar to be used.
Naturally, the ventriculoscope can be used freehand during the surgical procedure. However, for many indications, fixation is advantageous. For this purpose, a mechanical holding arm is available which attaches to the operating table to fix the endoscope. Using this system, the ventriculoscope can be reliably fixed with rotation stability in any position. Be put into any desired position. On the clamping jaw of the holding arm so as.
So this is a special hexagonal place and the lock. Earlier we had circular ones, so when surgeons were fixing it used to move a little bit. Now we have given a proper space and you do not lose the length. So if you are trying to get in the posterior part of the third ventricle, you need a longer length. So now you have complete 14 centimeters for your working length. You can have hands-on after the lecture. There is equipment displays there. You can do the
A
hands-on
special
training.
end during transportation and clean.
These are sterilization tray. I think
The
camera,
zoom and focus
everybody knows it. So how does it actually look into a real surgery on a high definition? Give you a glimpse because Dr. Vaibhav Pandey is already covering it.
Patient is placed
So we just give you a glimpse.
advanced into the right ventricle of the brain via the endoscope.
I'll just take you to one technical
Posterior
point.
commissure. Ventriculoscope is used again and the endoscope under endoscopic visual control.
Now
It is
there is a
very
special
important.
lure lock. So in case you are not sure whether you can pass through foramen Munro, you can open the lure lock, push this scope inside the endoscopic sheath and then travel together and check whether you can pass through the foramen Munro or not, or it is going to cut the edges of the fornix. So this is a very good lure lock which they have given, and you can check
The
whether you can
endoscope
pass
is
or not.
retracted into the endoscope sheath, veins in the area of the foramen of initial perforation.
So all instruments when you practice here has to open at 3 o'clock, 9 o'clock, not allowed to open 12 o'clock, 6 o'clock because you will not be able to see. This is a third ventriculostomy
The
forceps.
ventricle floor is
and-
done using the deck forceps, catheter filled with saline solution. Due to the configuration of the balloon, it needs to be inflated several times in order to achieve an adequate ventriculoscopy opening, which should be
So
around
you
4.
stay there with the tampering effect. The edges are going to get, hemostatic effect will be there. So no need to run excessive cautery here on the
millimeters in
edges.
diameter. The ventricular
So in case you want to, after you open the floor of third ventricle, you open the iliacus membrane, you want to have a glimpse from the basilar artery, use a 30-degree, push the light cable up because the basilar artery is in the pre-mammillary recess area, and this gives you a glimpse. Many times people are using 6-degree and trying to have a visualization in the pre-pontine cistern area, and that causes little trauma to the walls of the fornix. So
one
this
can
is the
identify
technique
the
to
basilar
see
artery with its branches,
the
which
basilar artery
indicates
and its
that
branches.
sufficient endoscopic visual control.
So
One
this
can
will
see
be
that
covered with Dr. Vaibhav. Now, the issue is one of the fear factor. If there is a case where the floor of third ventricle is non-transparent, non-translucent, and usually technique is that people come here and they try, below the infundular recess, they try to feel the bone, the clivus, the dorsum sale, and they keep coming down. Wherever they get space, they try to open there. Now, such fear factor can be overcome if you use the 3D 4K ICG technology recently launched by Karl Storz called Rubina, and use the indocyanine green drug, and you can see the basal cistern structure. We know the basilar artery is in the premammillary recess, but when you use this, you will be able to see where the vessel is there in case it is adherent, and you can make a precise opening over there. Have a glimpse. In the case of a triventricular hydrocephalus, the surgeon has used the camera indocyanine green, and you can see that here we see a vessel in this area. So you can go medially and make a safe opening in the floor of third ventricle and the establishment of CSF in the subarachnoid space. So this is how the surgery becomes safe by using this 3D 4K ICG technology called Rubina, which anyway you are using in your laparoscopy, in colorectal surgery, biliary surgery, or in varicocelectomy. So next topic is exoscope, which we call Vitom, video integrated telescopic operating microscope or operating monitor. People use different terminology. Storz has a good portfolio starting with Vitom 2D, 0-degree, then Vitom 2D with ICG, which you can use in different applications, then 90-degree, or very well accepted in gynecology for doing their NDVH and vaginal hysterectomies. And then you have Rubina lens, where I'll be showing you surgeon is using this handheld or with the holder in lymphojomas, fibrolymphoma, gynecomastia, thyroglossal ducts. So you get clear margins over there. And this gives you 16-time magnification, 1/6. So working with 7/0 suture or doing your hypospadias is pretty easy. So let's see how it is there. It's an economical solution. You directly put on the holder. Any camera system which is available, you can use that camera with this. Very simple. So let's see in a hypospadias how it looks.
To the OR table and sterilized if necessary.
So you lift it up 20
It
centimeters
consists of a
from the operating
high-definition
side.
television camera and a special optic with an attached the image instead of looking through a binocular
So from 20 to 75 centimeter, that's the length you get.
eyepiece is conveniently displayed on a 26-inch high-definition monitor, which offers a superior according to need. This 3.5-year-old boy had hypospadias repair complicated by a urethro-cutaneous fistula, which recurred after the flap will be anastomosed to 8 wings, which will then be brought together in normal location.
Just giving you a glimpse.
One corner of the flap is tacked into the desired location of the reconstructed urethromeatus with 7O PDS.
So with 7O
Down to the
PDS,
level
he's
of the
able to
Snodgrass.
use 2D
The urethral
Vitom
plate is
and
then
he's able to operate with that. Obviously, trials have been done. These are papers. They did about 20 cases, out of which 14 were hypospadias, then inguinal hernia, bilateral inguinal hernia were also used. You can see already trials have been done. So it's an economical solution. We have placed it. You can have hands-on over there. Let's see the Rubina lens with ICG on 2D. What is the application? How does it bring value in your surgical practice?
As you can see in my slides after, also in open surgery, what to this technology also in case of lymphangioma, or for example in these patients that have a huge lymphangioma of the neck, and you have to inject this product inside the lymphangioma, and you can use it to have a complete resection, because above all you can identify the lymphangiomas colored in green compared to the surrounding tissue that are not colored, as you can see on the right side at the end of the procedure. And you can use also in the dermoid kiss of the skull, and as you can see you can inject the shoulder, and we use the same technology to remove it, and you can.
So various applications can be used over there. Now finally, what is this Vitom 3D and what value it brings? So now the 3D gives you magnification 30 times. So you can work comfortably with 10-0 suture very comfortably and perform an anastomosis. We have placed the Vitom 3D. Have a look. I'll just show you the technology. It's a very small device which you see over here, and that is holding with the holding arm, and rest is the camera control unit. So you don't need a massive microscope. So these are the 3D, two 3D 4K sensor. Each 4K sensor is 1920 into 1080 multiplied by 4 times. So that brings you 8.2 million pixels. So 16.5 million pixels synchronized on a 3D monitor give you massive magnification, depth perception, etc. So this is a pilot which can be controlled by the operating surgeon. How much depth you want, magnification, you want to move cranial, caudal, lateral, medial, it can be controlled by your assistant or by the operating surgeon. And this is already displayed there. These are different holding arm. You can have a standard mechanical holding arm. You can have a holding arm which can be put on the OT table, or a trolley mount, or a high-end motorized holding arm like a robotic holding arm based on the budget. So this is a camera control unit. So let's see if in the surgery, some surgeries could be very long, very tiring. Why give strain to your neck by using loop and getting into a microscope when you can comfortably work with this? So here is a case. You can see that this surgery is from Denmark, in Alas University. The surgeon gets 2 monitors put on the boom arm. So you can move these 2 monitors, because when the assistant is assisting you from the opposite side, he needs a separate monitor. Everybody wears 3D glasses. I said 30 times magnification, and it's a very small compact device. You don't need a big, a microscope in front of you, and that occupies a lot of space. And up to 10-0 suture you can use. You get fantastic magnification, depth perception, And I think in most of your cases in pediatric surgery, because I'm new, I was told that 7080 sutures are used. So up to 100 is very comfortable. So based on the budget, this is a recording from pediatric mitral wall by Tokashi of Japan, where you can see the clear crystal image, depth perception, color contrast, image enhancement. So this recording is done from there. Now in the national television of China, surgeon was asked to come and show that can you quarter boil the egg, use this small device, Vitom 3D, go inside the glass and can you suture the skin of the egg without the egg yolk falling in over there, and he has used it. Of course, no tool in the world can replace the surgeon's skills which is developed over a period of time, but the technology helps you to see better and you can perform these surgeries with ease and shortening your anesthesia time. So surgeon was able to
Hello?
suture this.
Dr. Sunil Verma.
Yes, sir.
Sir, time is over.
Okay.
I think you bind up, please.
Sir. Finally, I just want to show you with the 10-0, I am done with this, that even with 10-0, you are able to perform suturing. This is done by resident doctor. We get two images because here we are seeing on the 2D. So here you methylene blue and on a 1 millimeter vessel using this Vitom 3D which is there, it can be used. But this is the last slide and conclusion that Vitom 3D is actually taking the advantages of microscope and endoscope. It is placed in between as per Jabalpur, university there, Dr. Vijay Pariyar, they run neuroendoscopy academy, fellowship training curriculum, where neurosurgeons come, they learn ETV and other procedures. So this is the last slide of mine, and I would like to thank you very much for your attention. If you have questions, please do come here. Please have some hands-on, especially the residents. We brought a lot of equipment from New Delhi, and you can have the real hands-on, and Dr. Pandey sir would be also supporting here. Thank you very much for your kind attention.